Sorry, one moment. There it is.
Great. Thank you so much, Lydia.
Thank you.
I'm Simone Kelly. I'm the Nurse Unit Manager from Radius Unit, and we've got Dr. Claire Keenan, who is our General Medicine Physician. And we just wanted to briefly, for 5 minutes, remind you all of our Radius Unit and our referral pathway with GPs and our inclusion criteria. So as hopefully many of you remember, we opened Radius in 2018, and it's a referral service directly for GPs and community services to avoid ED for patients with chronic medical conditions or acute exacerbations of their chronic medical conditions. We are a day-only unit, and we have a phone number that we accept referrals from you. So Claire's going to kindly just go through some of our inclusion criteria.
Okay, thanks, Simone. So as Simone has alluded to, we are an alternative pathway to the emergency department. So if you feel you've got a patient who needs to be assessed, you know, in the hospital setting but doesn't need admission, we are a good unit to consider. And just to sort of alert you to that, we are a medical unit, so we wouldn't accept any surgical presentations. So you can see on the flyer there some of our inclusion criteria. It's just some examples, it's not an exhaustive list. So, you know, anyone with cellulitis who you think might need intravenous antibiotics, back pain, DVTs, hypertension, who you think, you know, just need a bit of monitoring, perhaps some tests done. And, you know, we're willing to take your phone call and just discuss a patient, even if you're not sure, and we can, you know, give you some pointers. We may say, you know, perhaps that would be appropriate for us, or we may suggest ED, or, you know, hopefully be helpful with some other advice for you. So please do not hesitate to call us. We're always happy to take your call. And, you know, we're a physician-led unit, so your patient will come into the unit and be seen directly by one of the consultants and a very experienced set of nurses, so they're in good hands. So, yeah,
I think that's it for us. So please feel free to call us anytime. We're open from 9:30 till 6. We will, if we do accept your referral, we'll make a bed for your patient there and then. So we look forward to hearing from you all.
Thank you, Simone and Claire. And flyer will be sent out to today's attendees for your convenience and further referrals and information. Thank you very much.
Okay, thank you.
thank you.
And now I would like to introduce our facilitator for tonight, Dr. Philip Dwyer. Thank you very much.
Hi, welcome tonight. It's a pity that we can't have it at Hazelhurst. We're all looking forward to having it at Hazelhurst, but unfortunately circumstances have meant that we've got to go to the Zoom meeting. And thanks to Lydia and all the people at PHN and Rob Smith for being able to get together and organise the Zoom meeting on a short notice. And I'm sure it's going to be a great night. Still, as we all know, Rob Smith's been a cardiologist in the area for a very long time. He's been a visiting cardiologist at Sutherland Hospital, Sutherland Heart Clinic, Kareena Hospital, St George Private for many, many years, done a sterling service, and we've all appreciate the work that he's done. And he also gives a great insight into heart disease. And tonight, the talk is going to be on what I call just best practice for cardiology, what we probably need to know about looking after heart failure, ischemic heart disease. And there's really no one better to tell us about that than Rob Smith. So with that, I'll hand you over to Rob. Thank you.
Thank you, Phil, for that kind introduction. And welcome, everybody. It's lovely that you could join us. I'm sorry that I'm not there in person. I've not done these sort of Zoom meetings much anymore, so it is a little bit of a learning curve for me as well. I'm just going to get my slides up and see if we can introduce the topic. Okay. So I'm going to divide my talk into two areas. The first is going to be talking about ischemic heart disease, some aspects of that. And obviously it's a huge subject. I can't talk about the whole of cardiology tonight. And the second half is going to be on heart failure and management thereof, and the new ideas and concepts. So in terms of ischemic heart disease, one of the most important questions that GPs have is to assess cardiac risk. And I'll deal with that separately. And then the next area is going to be looking at chest pain or acute coronary syndromes. And then heart failure will be the final bit. So let's start off by talking a little bit about assessing cardiac risk. I just want to see if I can move these. Can you all see the full slide, or have you got my name and everyone else covering the slide?
No, full slide, thank you.
You can, okay, because I've got your faces across the slides. I'm just wondering if I can move that away. I'm not sure how to do that though. But anyhow, I can make it work. So patients often come up to you and say, look, I'm well, but I would really like to have my heart checked for various reasons, particularly family history is probably the commonest thing. And I guess what you need to do is profile their risk by looking at their individual risk factors. So age is obviously the most important risk factor in terms of increasing risk of coronary artery disease in particular. And then I think the next one, most important one, is to look at the family history and whether you're looking at a first degree versus second degree relatives. So if there's both parents having heart disease at a young age and all grandparents, that's a very, very high risk family. And then we'll look at lipids, look at their LDL versus the HDL level and triglycerides, and see if there's a constellation of both high LDL, low HDL, high triglycerides. And then look at blood pressure and whether it's normal, mild, moderate, or severe, looking at the individual risk. Stratifying cardiac risk, looking at other factors such as smoking. And on the screen over here, looking at something that's not always looked at is mood, depression, anxiety. I think that's often a neglected risk factor. More and more now we're thinking about sleep apnea as being an important risk factor as well. And often it's undiagnosed. It's quite an important thing that one should address. And then, of course, looking at body weight and exercise. And then just the other two things, well, lifestyle takes into account body weight and exercise, and diabetes and pre-diabetes. Many of our patients are not formally diagnosed as having diabetes, so they might have insulin resistance or be pre-diabetic, and that in itself increases the risk of vascular disease. So if you put all those risk factors together, you can come up with some sort of equation, and you know that all those risk factor calculators, they are useful, but they're not the be all and end all of working out the risk. So the patient says, I'd like to have a check. So traditionally in years gone by, the patients have been sent to us for a stress test. And the problem with doing a stress test is that it's a relatively insensitive test, because it only really will detect people with severe coronary disease. So you can have an absolutely normal stress test and have moderate diffuse three vessel disease. When we do a stress echo, we increase the sensitivity a little bit more, but even with stress echo, you can have a fairly normal stress echo and still have, moderate, maybe even, moderate to severe coronary disease. So over the last sort of 10 years, the early detection of coronary disease has been revolutionized by the use of cardiac CT. And we commonly actually do a coronary calcium score at the same time. The important thing about coronary calcium scoring is that it detects atheroma, and we always have to explain to the patients that it doesn't always detect early plaque. So in young people, you can have a coronary calcium score of 0 and still have non-calcified plaque. In middle-aged people, it's more sensitive to pick up coronary artery disease. So I commonly would say to patients that it's probably a good idea not just to do the coronary calcium score, but to also do the full CT angiogram, especially in people under the age of 50, so that you don't miss non-calcified plaque. So the gold standard is really a CT coronary angiogram. So many patients come to us and they're absolutely asymptomatic. They've got risk factors. And unless they have symptoms, it's probably not always worthwhile doing a stress test or even a stress echo. And I'm going to come to the new Medicare rules that sort of limit as to who can have a stress test and who can have a stress echo. So if a patient has symptoms, then it's easier to justify doing a stress test or a stress echo. And Medicare will actually cover that. If patients don't have any symptoms, then one has to think about the utility of doing a stress test. If patients have demanding symptoms and typical exertional angina, then the best place for them is to go to the hospital. And obviously we'd have a low threshold for doing a direct invasive angiogram to rule out significant coronary disease. If patients have symptoms, but it's atypical chest pain, then one would consider going straight to a cardiac CT, particularly if they have more than one risk factor or more than two risk factors. Now, what about the patients who are asymptomatic? So I'll come to that in a moment. Just going back to this slide over here. So these are the Medicare funded indications for doing stress echo in 2021. There's a couple of parts to it. If a patient has not got any known coronary disease, they've never had an angiogram, never been documented before, and they have symptoms that are consistent with angina, then you can definitely justify doing a stress echo and Medicare will cover it. The other indication is if the patient's asymptomatic and they have an ECG, which is suggestive of ischemic heart disease. So this is a pretty extreme case, but you do sometimes see people who have ST segment changes. That is adequate to justify doing a stress echo as well. So symptoms and an abnormal ECG. If the patient has documented known coronary disease, so they may have had a CT angiogram in the past or proper angiogram, or they've had bypass surgery or they've had stents, then another indication for doing a stress echo is if they have some progression of symptoms despite the fact that they are on medical therapy. So someone comes and says, I'm getting more exertional chest pain, then you can certainly do a stress test on them. The other indication is if you have done a previous angiogram or a CT angiogram and they've got moderate disease and you're trying to follow them to see whether they are developing ischemia, that can be classified as an indication for doing a stress echo. And the third indication is if you're worried about silent ischemia, and that's something that can be a little bit tricky because the patients, you have to have a high index of suspicion that they might be getting ischemia. So the way you can justify that is if there's language difficulties, the patient can't explain to you, if they've got cognitive issues, memory issues, and if they're a poor historian. The other big thing for silent ischemia, which I haven't put on that slide, is if patients have diabetes. You know that many diabetic patients have occult ischemia. They have no symptoms other than perhaps fatigue or dyspnea. And you can certainly do a stress echo in someone like that, particularly if they've got long-standing insulin-dependent or even non-insulin-dependent diabetes. Sometimes we can justify doing a stress test in people who are asymptomatic, but they've got a lesion that might be particularly risky in terms of causing an acute coronary syndrome. And you can test what's called the ischemic threshold of a prognostic lesion. So someone who's got a 60% LAD lesion and you're not sure whether they need to have it fixed or not, have an angioplasty, you can then do a stress echo to see if you can provoke ischemia. Part C for the indications for stress echo is what they call a functional assessment. So this is looking at the impact of coronary blood flow on heart function. So if you've got someone who's got aortic valve disease and you're thinking of potentially sending them for aortic valve surgery or even a TAVI valve, you can do a stress echo to see if there's any indication that they've got coexistent coronary artery disease. Same applies for mitral valve disease, someone who's being considered for a mitral valve replacement. And this one over here is like a basket that I think is important, because so many of our patients complain of shortness of breath. And you often think, could this be ischemic symptoms manifesting with breathlessness? No chest pain, but just breathlessness. So this is a very common sort of referral that I get. And it's often in an elderly person who's put on a lot of weight, they become deconditioned, and their biggest complaint is they get so breathless when they walk. And one would like to rule out coronary artery disease as being the cause of the breathlessness. So that's quite a legitimate reason to do it as well. And the question is, how much should you push the patient to find out if they're breathless or not? And the other thing in functional assessment is for patients who are going to have intermediate or high risk surgery, in patients who are known to have significant coronary disease. So someone who's got known moderate disease, or have they got left ventricular failure, they've had previous TIA, they've got chronic kidney disease or diabetes, and they're now going for, let's say, a colectomy for cancer, or a hip replacement, or a knee replacement. And it's going to be a fairly long anesthetic. And the anaesthetists are concerned about how safe they will be, and whether you need to make sure that they haven't got any major sort of risk for their heart during the operation. So that's also quite a big basket. Now, what about patients who come to see you who've had new onset chest pain for the very first time? You take a history, and the history is very suggestive of exertional angina, then you would refer that patient for a stress echo. If the chest pain's occurring at rest, and it's a typical story of dull central crushing pain going into the arm or into the throat associated with dyspnea, the best thing to do with that patient is to send them to hospital straight away, because a certain percentage of those patients will have an acute coronary syndrome and will need to be admitted and maybe have an invasive angiogram and an angioplasty, or even bypass surgery. If the pain's atypical, then the best strategy is to just use your clinical judgment. And if they've got lots of risk factors, but the story is a little bit atypical, then you might still send them to emergency. If they haven't got many risk factors, then you'd obviously think of alternative diagnoses. And we'll think of other pathology. And one of the common ones is pericarditis. So you'll try and do an ECG, and you'll see that they've got some global ST elevation. You can see that the ST elevation is in lead 1, 2, leads 3, and also across the lateral chest lead. This is a common ECG for pericarditis rather than for an acute coronary syndrome. And of course, the other thing is aortic dissection, and the different types of aortic dissection. And the pain here would be more in the back, it would be more tearing, and patients are often very unwell with that. And this is a medical emergency. So clearly, if you're thinking aortic dissection, first place is straight to emergency department without having an urgent CT aortogram to rule that out or root it in. And the non-cardiac chest pains, which you'll see more than likely is the most commonest cause of chest pain, and reflux can sometimes, for a patient, seem almost identical to angina. So that's something that you always have to, and the patients often have difficulty distinguishing reflux from angina as well, but you need to consider that. The other thing is if they've got pleurisy, and they might have a small pleural effusion, and the pain will be much more pleuritic. And the commonest one, and I've just put this jar of tiger balm here, is mechanical musculoskeletal chest wall pain. I'm sure you all know how to elucidate that history, but that's by far and away probably the commonest cause of a chest pain presentation to a GP's office. So if it's a typical chest pain, you want to, and it's at rest, and it's a new onset, technically that's unstable angina. They go to the hospital, they have serial ECGs, they have troponins. If the ECG and troponins are abnormal, then usually what happens is that the patient will have coronary imaging, and if the troponin's up, it's usually an invasive coronary angiogram, and then take it from there whether they need revascularization or not. If the story is suggestive, but the troponin is not particularly high, and maybe the ECG changes are subtle, we can sometimes do a CT coronary angiogram in the hospital. And we're now more and more actually having the facility to do the CTs in the hospital as an acute procedure, rather than having to send them to a radiology facility outside the hospital. So which test you do depends on the clinical scenario. If the patients have a raised troponin in hospital, then almost always we will put them on dual antiplatelet therapy with either ticagrelor, Brilinta, and aspirin, or clopidogrel and aspirin. The problem with doing that is if you're really worried that they may have multivessel coronary disease, so it's an older person, they've got lots of risk factors, often what you would do is do an angiogram and not give them dual antiplatelets, because if they need bypass surgery, you have to wait about 4 or 5 days for the clopidogrel to wear off before the surgeon can safely underdo the bypass operation. The patients are also given intravenous heparin or Clexane. Usually they're started on a high-dose statin if they're not on that, and a beta blocker as well. So these are all the fundamental 4 drugs that are used in anyone who's got an acute coronary syndrome. And commonly, if the blood pressure is high, we would use a nitrate and add in an ACE or an ARB to help control the blood pressure, or even a calcium channel blocker. But if they're having ischemic pain, then a nitrate would be the drug of choice. So with cardiac catheterization, you get immediate information as to exactly what the state of the arteries are, and you can decide then whether it's medical therapy, angioplasty, or PCI, or versus surgery. And what we do is we do what's called the syntax score. So the syntax score is a way of scoring the severity of the disease by looking at the arteries. We work out how many arteries are involved, how many lesions there are in the artery, how long the lesions are, and do the lesions involve a bifurcation in the vessel. And the higher the score, the more likely your patient will be referred for bypass surgery rather than angioplasty. And now, quite commonly, we do that score in any patient who has a cardiac catheterization, so we can kind of stratify what's the best way to do them, to revascularize them. The other important thing to look at is someone who has a stent or a bypass is age is a major determinant. People over the age of 85 don't do as well with bypass surgery because the operation is quite a big onslaught on their body. The recovery time is much longer, and they often need a much longer time in hospital and rehabilitation to get back on their feet. We look at other factors as well. So comorbidities are important. If someone's got diabetes, in general, they tend to do better with coronary bypass surgery than angioplasty and stenting. If someone's got chronic kidney disease, it depends how bad it is, but multiple attempts at angioplasty with using lots of contrast can worsen their kidney disease, but putting them onto bypass operation can also be a risk factor for worsening their kidney disease. Bad respiratory disease is a contraindication against bypass surgery, and we often would do a number of angioplasty and stenting procedures, maybe not all at one go, but bring them back and do it over 2 weeks so that they can be fully revascularized, because once you put them on a ventilator, it's going to be a much longer, difficult course for them to recover. And the same applies to cognition. People with cognitive impairment are better off having angioplasty and stenting, and obviously cancer patients, it's better if you can avoid a major big operation, particularly if they've got advanced cancer. Okay, and this is another big aspect to what you do in your surgeries every day, and that is patients who are breathless. Is it heart failure or not? And the history would involve finding out if there's any prior heart disease. Is there any history of hypertension? The reason why hypertension is so important is because people with long-standing hypertension get major diastolic dysfunction of their heart, and you get heart failure with preserved ejection fraction, called HFpEF, as opposed to HFrEF, which is heart failure with reduced ejection fraction. So people who have had ischemic heart disease, if they've had previous myocardial infarction, the heart is damaged, they've got much higher chance of developing heart failure with reduced ejection fraction. But the clinical presentation in the rooms can look identical. They have dyspnea, they have edema, they have crackles in their lungs, raised JVP, and that's why it's important to, in heart failure patients, investigate them further to work out what the mechanism of the heart failure is. Obviously, valvular heart disease is important, and particular mitral regurgitation and aortic regurgitation, which cause volume overload and heart failure. Aortic stenosis will give you, in its severe stages, heart failure with preserved ejection fraction because of the severe left ventricular hypertrophy that occurs in order for the heart to compensate against the stenosis aortic valve. And then there's a whole group of cardiomyopathies. The commonest one is which dilated cardiomyopathy, and that will cause heart failure with reduced ejection fraction. Commonly, the patients have a history of this, but not always. And there's certainly, recently we've had some young people who've had come in with acute dyspnea, and it hasn't been recognized that they've actually got an acute cardiomyopathy, which has been triggered by a recent viral infection. I've had a couple like this recently who've actually ended up bouncing from one doctor to another, ending up in emergency. And even in emergency, they missed it and they sent the patient home, went to another GP, came back, and eventually it took a while. So you always have to try and make sure that you're not missing a case of acute viral myocarditis causing cardiomyopathy in a young person. It happens rarely, but when it happens, it can be devastating. So the symptoms, if it's mainly left ventricular dysfunction, then shortness of breath, orthopnea, paroxysmal nocturnal dyspnea. In RV dysfunction, and remember with cardiomyopathy, they often have both LV and RV dysfunction. They get edema, weight gain. Abdominal swelling is important because a lot of these patients can sometimes present almost like an acute abdomen. We've had a few young people with cardiomyopathy that they would look like it might have been a surgical abdomen. And one or two have actually gone to theatre for what was thought to be appendicitis, and actually turned out that it was acute viral cardiomyopathy causing congestion in the liver, congestion in the gut, causing acute abdominal pain. So it's rare, but something to always think of. And nocturia is a new symptom often in patients with severe right heart failure as well. Clinical signs, it's easy. This is medicine 101. So for left ventricular dysfunction, enlarged heart, you can often hear a third or fourth heart sound. There's pleural effusions, which are sometimes not easy to find clinically, and that's why a chest X-ray is very useful, and crackles in the lungs. If it's significant heart failure, the worse the heart failure, the faster the heart rate and the lower the blood pressure. And in right ventricular dysfunction, it's obviously edema, raised JVP, and abdominal distension due to ascites. You always have to think of excluding other factors that could potentially worsen heart failure or present as dyspnea, which might masquerade as heart failure. And alcohol chronic lung disease is important. Sometimes someone has, long-standing asthma, which has not really been picked up, and I'm sure that that can sometimes present as an acute respiratory distress syndrome. Anemia, always think of that, and iron deficiency is the commonest cause over there. Thyrotoxicosis, chronic kidney disease. Chronic kidney disease can lead to a fluid overload state because of difficulty in filtration of urine, and patients can present with edema and ascites and pleural effusions, and it's actually not heart failure, it's just chronic kidney disease, and particularly nephrotic syndrome. Obesity and its association with sleep apnea, again, another very common scenario presenting with acute dyspnea that can masquerade like heart failure. And then it's just a group of people who just are they've put on a lot of weight, they are so deconditioned, and it almost looks like they've got heart failure, and they can hardly do anything. And, it's something that can sneak in under the radar, and you always have to, exclude everything else, but sometimes that's what it boils down to. The other one that I've seen a few is people with occult sepsis, where they've got bacteremia, septicemia, and it can be due to even a UTI, and it can appear, it can masquerade as acute severe dyspnea. So obviously some basic investigations need to be done. The routine blood tests, BNP is very useful because that will help you to sort out whether it really is heart failure. And it's a test that we don't always do. Thyroid function tests are very useful as well, but all the routine blood tests, the chest X-ray is mandatory. An ECG, just to look at rhythm, is it often patients have an irregular heartbeat, is it atrial fibrillation, or is it sinus rhythm with lots of ectopics? And look to see if there's any ST segment depression, T-wave inversion that might suggest ischemia or infarction. But the gold standard test is an echo, and the echo will tell you whether it is systolic versus diastolic dysfunction, and it will also tell you whether there's any significant coexistent valve abnormality. With patients who develop heart failure, they often get dilatation of the annulus, or both the tricuspid and mitral valve, and they then develop functional mitral and tricuspid regurgitation, which can sometimes be quite severe. And as you treat the heart failure, the heart shrinks a bit and the valvular regurgitation improves. Also, to think of a pericardial effusion, that can present, if it's been building up as a chronic effusion, with quite marked severe signs of right heart failure with ascites, raised JVP, and edema. Now, just to go through the treatment algorithm, the first thing when someone has got acute heart failure is to control fluid overload. And we always would start off with a diuretic, and that's initially the drug of choice to get the patient comfortable. And usually we would use a drug like Lasix, a loop diuretic, and nowadays commonly adding in aldosterone antagonists such as aldactone or alplarinone. And if the heart failure is refractory, we can add in a third diuretic such as a thiazide. The problem with using the 3 diuretics is you run the risk of causing acute kidney injuries. You have to be very careful. It is important also to tell the patients about fluid and salt restriction. And if they're carrying a lot of weight, calorie restriction. Vasodilator therapy. So ACE inhibitor therapy is first line. It's better to use an ACE inhibitor rather than an angiotensin receptor blocker. And we usually start on a low dose and build up progressively to the maximum tolerated dose. It's important to try and get the patients onto the maximum dose because you get more long-term beneficial effect on the heart at the higher doses, and obviously monitoring blood pressure and renal function. Often you see people with quite severe LV dysfunction and they're only on a very small dose of an ACE inhibitor and their blood pressure is 140. So we really want to titrate the dose up to the blood pressure is about 110, between 100 and 110 systolic, as long as they're not getting postural dizziness. If they don't tolerate the ACE inhibitor because of cough, then obviously an ARB is the second line drug. And if the blood pressure is still high, then we add in a nitrate as the third line drug, particularly if they have ongoing heart failure. So getting the blood pressure under control is a very important part of treating the heart failure. And occasionally, not commonly, you need to add in a fourth drug, and that can be a dihydropyridine calcium channel blocker such as amlodipine or felodipine, or you can use a drug like hydralazine as well. But that's a very uncommon scenario for in heart failure that people need a fourth drug. And then just to remind you about the use of Entresto. So Entresto is a relatively new drug. So it's a combination of an angiotensin receptor blocker and a neprilysin inhibitor. So it's a cubitril together with valsartan. The PBS guidelines are that the patient has to initially have been either on an ACE inhibitor or an ARB before using it. And the important thing about this drug is that you need to have a washout period of 36 hours if they've been on an ACE inhibitor. Otherwise, they can get an acute hypotensive reaction and side effects if you don't have the washout period. And again, you up-titrate the drug to the maximum tolerated dose. The maximum dose is 97/102 milligram twice daily. But many patients can only tolerate much smaller doses. And even if patients have got a very low blood pressure, you can start them on the lowest dose, the 24/26, half a tablet twice a day, and just take it very slowly, build it up over a period of weeks to months. And it's amazing how the patients accommodate to the dosage and they can tolerate it quite well. The good thing about this drug is it does have about a 20% reduction in mortality and in rehospitalization, which is more potent than the effect of ACE inhibitors or angiotensin receptor blockers alone. Beta blockers, we now use heart failure specific beta blockers, and there are the 4. The top 2 are used most commonly now. We used to use a lot more carvedilol early on and metoprolol. The problem with carvedilol is it does sometimes lower the blood pressure too much, whereas nebivolol and bisoprolol are a little bit more gentle that way. And we progressively up-titrate the dose to the maximum tolerated dose, depending on blood pressure and pulse. The pulse that we aim for is somewhere between 50 and 55, and the blood pressure is the same, 100 to 110. What I tend to do is, instead of giving the drug once a day, I tend to split the dose. So instead of giving bisoprolol or nebivolol 10 daily, I give it 5 milligram BD because it's generally better tolerated if you give it as a BD dosage. And patients have less postural dizziness during the day, which is important because you want to make sure that they can avoid syncope. Fourth line agents, if the heart rate remains above 77, then we add in Corellan. And the beauty of this drug is it doesn't lower the blood pressure at all. 2.5 milligram twice daily, and then up titrate the dose up to a maximum of 7.5 milligram twice a day. So this is added if the patients are already on a beta blocker and you can't get the heart rate to 55, or they're on a beta blocker and the heart rate's fast, but the blood pressure is low, so therefore you can't push the beta blocker dose higher. So there are many patients who've got really bad left ventricular function, ejection fractions of, let's say, 20, 25%. They can only take a very tiny dose of beta blocker, but they tolerate the ibabradine because it doesn't lower the blood pressure, and you use that in conjunction with a beta blocker. Digoxin used to be used a lot, but it's really wouldn't say historical, but it's mainly used for patients who are in atrial fibrillation to control the heart rate better, particularly when they have an intolerance of higher doses of beta blocker because of low blood pressure. In a small group of patients, it does seem to help heart failure per se, without necessarily working just for atrial fibrillation rate control, but it's largely a drug that's now being relegated to fourth or fifth line use. And the reason for that is because ditch toxicity is a problem, and especially in elderly patients, can cause a lot of side effects and morbidity from the ditch toxicity and the side effects of digoxin. Other measures, you always got to think of these things. So salt restriction is always part of managing heart failure. Fluid restriction, patients often find it very difficult to adjust to this. So in wintertime, it's a bit easier because I say to them, look, it's not so hot. Try and stick to 1 to 1.2 liters. And calorie restriction is important. Exercise is important as well. And the patients often go to cardiac rehab at the hospital or anywhere else where they are given specific group instruction in terms of the kind of exercises that they can do, and they have them on a maintenance program that they come back to. Recognizing and treating sleep apnea, that's an important part of managing heart failure as well, because many of these patients have not just ordinary obstructive sleep apnea, but central sleep apnea as well. And that is a very important part of managing heart failure. Increasingly, we've recognized the importance of iron supplementation. Iron deficiency worsens heart failure. Iron is an important substrate for myocardial contractility. So we routinely measure iron, and in hospital, the patients are given intravenous infusion of Ferinject, which is, as you know, replacing the old iron, which is sucrose ferrous sulfate. And but given in the outpatient setting, we can still put them on an iron supplement as well and keep the iron level. The important thing is to keep the transferrin saturation above 20%. So it's not, and the ferritin above 100. That's your target level for iron supplements. Ferritin above 100 and transferrin saturation above 20%. And one of the things that's often neglected is treating anxiety and depression. Many of these patients become very isolated, depressed, and if you can improve their mood, that does help heart failure as well. So SSRI drugs can be used and should be used. Now, one of the final aspects is to look at underlying causes. In patients with poor LV function, you always have to ask yourself, do they have underlying coronary disease? And if they do, then that should be revascularized with stenting or with bypass surgery. So we often will do a coronary angiogram in a heart failure patient to make sure that that's not required. Valve replacement, if they've got severe MR or severe AR, then replacing or repairing the valve is important as well. Increasingly, devices are also playing a role. So there's lots of different devices now. Now, if someone has got heart failure and they have very bradycardic, we can, in a small group of them, put in a conventional pacemaker, which will give them rate support, and then you can give them more beta blockers. But commonly with these patients, we use a biventricular pacemaker because that will pace both the left and the right ventricle. If you give them an ordinary single chamber pacemaker, pacing one ventricle, often that makes heart failure worse. And in patients with very poor ejection fraction, who have had some ventricular tachycardia, we have to think about whether they need a defibrillator as well. So it's not uncommon now to see many of the heart failure patients having a combination of a biventricular pacemaker, which will pace both the left and the right ventricle, and a defibrillator all in one device. And that's now really almost the gold standard in terms of managing people with poor left ventricular function who've got VT or have had VT and have got a broad QRS complex where the QRS is broader than 0.15 ideally. The broader their QRS complex, the more the benefits of the biventricular pacemaker. Advanced heart failure, I think this is the last slide. So there are unfortunately a group of patients who are very, very severely affected by heart failure. We hospitalize them. They sometimes can be given temporary help and relief by giving them inotropic support with dobutamine. We give them a constant infusion of Lasix, like 10 milligram per hour. They have obviously very careful supervision of their renal function. And there's a very powerful special diuretic drug that we can use called metolazone, which diureses them. And in patients who are very end stage, we can refer them to the heart transplant clinic at St. Vincent's, and they have new devices, which are mechanical implantable ventricular assist devices. There's another one called the impeller, which is put in the aorta, but this is all with very end stage. I've not had many patients with this. It's a very end stage thing, and it's often used as a bridge to a heart transplant. So the final solution, of course, is a heart transplant, but the selection criteria are very strict for patients who are going to have a heart transplant. But it is something to think about in people who are under the age of 65, don't have any other major problems like severe kidney disease, severe lung disease, or cancer. And I've got, I think in my career already, about 3 or 4 patients that have successfully had a heart transplant and are now doing very, very well. So I think that's probably the end of the formal part of the talk, but I think Philip's got questions. And we can take some questions and more discussion.
Okay, Rob. Yes, we do have some questions. First off, from Lucy, do you think women just after the menopause should be looked at similar to younger people in terms of the risk of new plaque? So is the benefit of cardiac CT more useful in this group?
Well, postmenopausal women are obviously at higher risk than premenopausal, but I think you have to look at the individual risk profile. So if they've got other coexistent risk factors like hyperlipidemia, family history, diabetes, smoking, hypertension, all that sort of stuff, the more risk factors they have, the more you would have a very low threshold for doing a CT coronary angiogram. And this is obviously in asymptomatic patients that you're screening them for early plaque. The only issue with that, of course, is that the patient has to pay for it. But I always tell the patients that if we pick up your heart disease at a very early stage, it's money incredibly well spent, because you're going to have the opportunity to address your risk factors with a lot more enthusiasm and with pharmaceutical intervention, and hopefully prevent yourself from developing much more serious heart disease later in life.
Okay, thank you. From Alexander, how much are CT coronary angiograms if the GP orders them? And is there anyone in particular that you feel does that better than the others?
I think if it's a non-Medicare rebated CT, then it doesn't matter who's ordering it, it's the same cost. If it's Medicare rebated, then the cardiologist has to tick a box on the referral form and fill in the right information, and then Medicare will pay for most of it. I think the out-of-pocket cost for the patient is about $100 versus $450. But to do a Medicare rebated scan, the patient has to have risk factors and has to have symptoms that would otherwise have indicated the need for an invasive angiogram. So I guess Medicare is looking at exactly who's getting Medicare rebated scans and who's not. I mean, they don't care about the non-Medicare ones because that's the patient's money, but it's the government's money. And I haven't heard of anyone being audited yet, but I'm sure it's going to happen with all the new rules that are coming in. Who do I send them to? I think, in the Shire, we've got a few radiology practices that do them. Shire Imaging does a wonderful job. I mean, I think the reports are actually then co-reported by a cardiologist and a radiologist, whereas at the other big practice, can't think of the name now, but the other one, it's mainly a radiology reported one. I think, I guess it just depends on who you got the most faith, but I tend to use the Shire Imaging as my main referral for doing CT angiograms.
Okay, thank you. Are there any red flags on history that would make us more suspicious of a viral cardiomyopathy?
Yes, well, I think in that situation, it's often a normally healthy, fit young person who had a non-specific illness, which was like a flu-like illness, and has been absolutely, very slow to recover, and says that since they had this like myalgias and arthralgias and maybe a low-grade fever, maybe a bit of an URTI as well, they've just felt absolutely terrible and they've been breathless, which is unusual for them. So the breathlessness is the big thing. Normally these are, I'm just thinking the last couple I've had, they've just said, look, I'm normally out playing sport all the time, and now I'm just really struggling. I don't know what's happened. I've lost all my energy. So those are the things. That's a sudden change from being absolutely like active and fine to suddenly finding that someone's pulled the plug out and you just can't do anything. And they don't always have signs of heart failure. That's the problem, because people, looking, the lungs might be fairly clear. I mean, as time goes on, the heart failure signs will come. But I think in someone like that, what one should do is do a chest x-ray to see if there's any pleural effusions, because that'll be the first thing that will happen, is I'll get some more pleural effusions. And the blood test that you should do is the BNP. That is usually elevated quite early on if they're developing significant left ventricular dysfunction.
Okay. Actually, there's another question. There's a question here about BNP.
Yeah.
Is it Medicare rebatable? It used to not be.
I think it is now, but I think there's still a bit of a charge. They've got new kits for BNP. In the old days, it used to cost the patient like $50 or $100. But I've heard now that it's not always 100% rebated by Medicare. There might be a small gap, but I don't think it's big. I think it's just, it's dollars. I don't think it's a lot of money, because the testing kits have come down in price.
And talking about viral illnesses and cardiomyopathy and heart failure, just an observation, you can turn around and say just coincidental, but with some of the oldies, a number of times they've gone into failure and they've had a viral illness, and then they've also then developed atrial fibrillation, which then seems to have thrown them into failure. Is that more the viral illness giving a cardiomyopathy that then threw them into AF, or was it just a coincidental thing, or what? Okay,
so I think the commonest scenario is that any infective process, be it viral or bacterial, in an older person can precipitate atrial fibrillation. And if you have atrial fibrillation with a rapid response and it goes for a period of time, that causes heart failure. So that's by far and away the commonest scenario. So most of these patients may not even have any significant underlying heart disease, but because they've developed some sort of infective process, they've then developed AF, and then they get heart failure. And it's often even patients who've got normal LV function. The longer the atrial fibrillation persists for at a higher rate, the worse it affects the heart function. And eventually they develop systolic dysfunction and cardiomyopathy. So if you get on top of the AF and you control it, and hopefully maybe even revert it to sinus rhythm with cardioversion, the left ventricular function can recover and the patient can be completely normal again. But there is also a chicken and egg argument. So what came first is the infection, and then AF, and then heart failure. But people who've got poor LV function also get atrial fibrillation, and that makes the heart failure worse. So even in people who've not had AF, if they're developing heart failure, they can then get a secondary atrial fibrillation because of the dilatation of the heart. So the atria get bigger because of the heart failure. Then the bigger the atrium, the higher the chance of getting atrial fibrillation. They go into AF, and then it makes the heart failure worse because the heart is beating so fast. And many of these patients don't even know they got AF. They don't complain of palpitation. They just suddenly know that they're feeling terrible. They're very breathless. They're lethargic. They come to see you. You take their pulse and you say, "Oh, your heart's going 150 beats a minute. Can you feel it?" No, not at all. So particularly in the elderly, they're kind of oblivious to the actual palpitation. They don't complain of palpitation. They just complain of the systemic unwellness of heart failure and breathlessness. Yeah.
So if that's the case, do we ask for an echo on a lot of our oldies who we pick up have atrial fibrillation?
I think everyone with atrial fibrillation, if they've not been worked up, should see a cardiologist at some stage just to work out what we should do about it. I mean, if they have AF and it's a new onset, it's always worthwhile considering getting them back into sinus rhythm. And the beauty of sending them for an echo is you can see whether they've got huge left atrium, whether they've got significant LV dysfunction. So if you look and the heart looks bad and the atrium's big, you can surmise that they've probably been in AF for a long time. And the strategy then may really be, especially if they're quite old, is just treat the heart failure with all the relevant drugs and control the heart rate with beta blockers and DEG, and if necessary, amiodarone, and anticoagulate. So I think anyone who has got AF, it's worthwhile them at least having a cardiac appraisal to try and work out, firstly, why they've got AF, and number two, can we get them out of AF, or are we just going to go for long-term anticoagulation and rate control?
Okay. From Alexander, should I switch HF-REF patients from standard metoprolol BD to metoprolol XR?
It is not a huge difference because the drugs are essentially the same. The beauty of the XR is that it's a more smooth release. It hasn't got a peak and then a trough and then a peak and then a trough. So in general, I think if someone's got reduced ejection fraction HF-RF, then I would use the long-acting formula because it has a much more gentle effect on blood pressure. You don't have that big swing of a dose in the morning, the blood pressure comes down, then it wears off, and then you take another dose in the evening. So the short answer is yes. If you're going to use metoprolol and it's heart failure, it's best to use the long-acting, the XR metoprolol.
Okay. And any preference of ACE inhibitor, ramipril versus perindopril, or any others? Which...
Look, to be honest with you, I think they're all very good drugs. I think I tend in heart failure to use the drugs BD for the same reason, because a lot of these patients find that if you give them the maximum tolerated dose in the morning, they tend to get periods of hypotension in the afternoon and feel quite lightheaded and pre-syncopal and could even collapse. So I tend to use mainly perindopril because I think all the main heart failure studies are done with that, and ramipril as well. Those are the two ones that I use. And I tend to, in most cases, especially in older, more frail people, if possible, and especially if they've got a Webster pack, I make sure that they have it BD. So I'll rather use perindopril like 2.5 BD than 5 daily, or ramipril 5 BD rather than 10 daily. And the other reason for that is that it protects them from that very significant early morning surge in blood pressure when they wake up, because they haven't got any ACE inhibitor on board when they take the whole dose in the morning. So I think it works better. I think it's physiologically more superior, and it's less likely to cause postural syncope.
Okay. And GPs can refer to cardiac rehab as outpatients without any problems normally, can't they?
Yeah, I believe so. I think you can contact cardiac rehab at Sutherland Hospital or the SHELT team. So the SHELT provide a home service as well, and they have rehab class, so heart failure support groups in the hospital as well. And they are contactable via Southcare. and you can certainly refer directly to them.
Okay. A question about AF associated with exercise level, especially marathon runners. And is there an exercise level that is associated with increased risk of AF besides marathon runners?
Well, so people who do very, very high levels of excessive aerobic activity do tend to have a high incidence of atrial fibrillation as time goes on. It's very variable from one person to another. And the reason for it is there are two major reasons. Firstly, as you get superbly fit, you tend to get more sinus bradycardia. And as your heart rate gets very slow, often what happens is that you reach a point where you go into almost like a junctional rhythm. And then as an escape, you get atrial fibrillation. Also, what happens is that because people are pushing themselves at very high levels of physical performance and endurance, they tend to get quite big atria. They get an atrial dilatation, and that predisposes them to atrial fibrillation because of this increased stretch force on the atrium. And the reason that happens is because they have a slow pulse, they get a very big stroke volume from their hearts. And that means that the atrium has to be compensatory, much larger in size. Now, it's very hard to say what's good for one person, what's good for another person, because there are plenty high performance athletes that never get atrial fibrillation. But we all see athletes who are extremely bradycardic, and sometimes they're that bradycardic that they get pre-syncopal. And these are the ones that are at risk, and they almost certainly will, if they don't back off a bit on their training, will eventually almost certainly get atrial fibrillation. And then it can become an incessant, repetitive, chronic problem.
Okay. A question somewhat on hypertension. Can we use ACE inhibitors and ARBs together in hypertension or other conditions? Or do you feel that they should probably be just used individually?
So in days gone by, we used to commonly use ACE and ARB, and there is some theoretical reason why it works well. And then there was some research to show that if you do combine the two, there's an increased risk of acute kidney injury as time goes on. Now, all of us in our practice have patients who traditionally have been on an ACE and ARB for years and years and years, and they're doing very well. And I always look at them and they're fantastic. They've got excellent blood pressure control. Their renal function is normal. So I leave it. I don't take them off it. But there is certainly people that all of us have had that have been on the two drugs together that have actually done badly, and they've developed significant renal dysfunction. In this modern era, I never actually initiate patients on both drugs. I never put them on an ACE and ARB at the same time. We have such a wonderful armamentarium of antihypertensive treatment now that we really don't need to do that. But sometimes I kind of have people that I'm really struggling with their blood pressure, and I think maybe I should do what I used to do 30 years ago and use both drugs, because there's no doubt that it is very potent if you combine an ACE and an ARB together. But yes, it's not recommended. The renal physicians don't like it, and there is a lot of theoretical reasons why we shouldn't do it, and I think in general try and avoid it.
Okay. From Asha, a question. I presume it's how aggressively do we treat systolic hypertension in the elderly?
Now, it's a very complex thing, that, and I think we need to look at how is the patient functioning? Do they have postural symptoms? Many of these patients have quite marked systolic hypertension, and when they stand up, they get a very big postural drop, and then they fall and hurt themselves, and that can be catastrophic. So I think if there's big postural drops, the risk of treating the systolic hypertension the benefit is outweighed by the risk of syncope when they stand and walk around. If they've just got systolic hypertension and they're not getting too much of a postural drop, then I gently would lower their blood pressures. Now, when the elderly, I'm talking over the age of 80, and I try and aim for a blood pressure of about 150. I never try and get it down to 120, 130, especially if patients have had these very high readings for many years, because they've often got quite marked arteriosclerosis of their cerebral circulation, and they need that higher pressure to maintain adequate cerebral blood flow. So I think you just got to individualize it, but I think it's a very tricky area. And I think sometimes overzealous antihypertensive treatment in the elderly can have much more harmful effects than beneficial effects, especially in the very elderly over the age of 90.
And the other question there is obviously, how aggressively should we treat diastolic hypertension?
In the elderly or in anyone?
That one's just treat diastolic hypertension, I guess.
Well, I think we should. I think in middle-aged people, diastolic hypertension is very important, because I think that is almost certainly the most important aspect of how hypertension damages vasculature. So yeah, we should definitely aim to get people's diastolic blood pressures in middle-aged people down to about 80 diastolic. In the elderly, often they don't have too much diastolic problems. It's mainly systolic. But I think in people between the ages of, let's say, 35 to 80, we should definitely treat the diastolic pressure down to readings of about 80. That would be my target.
Okay, that's good. I think that I'm just having a look to see if there's any more questions coming through.
Right.
Another question on using statins. Is there a time when we don't, continuing statins? Some of us who are looking after the oldies in nursing homes and places like that, they turn around and say they still need to have their statins. But my feeling is, if they already have some cerebrovascular disease and they already have some ischemic heart disease, and they're tolerating a statin, if they're able to swallow it, and that, it's probably all right to continue using that until the very end. Is that reasonable?
Yes, I think so. I think one of the reasons why these people have become very old is because they've been on statins and they've not had major recurrent heart attacks and strokes, and they're still alive. So if they're tolerating it, there's no major side effects, and they're doing well, I see no reason to stop it. Some of the geriatricians like to deprescribe, and they say, oh, look, this person's now 90. What point is there anymore? I say, well, I think there is a point, because they are still having some quality of life. They might be in a nursing home. They haven't had a stroke. Often you find that if you stop the statin, a few months later, there's a heart attack or a stroke. And then you think, oh, God, I should have done that. So I'm not a great sort of person in recommending stopping statins in people just because they're old. I think they are old because they've been on statins and they've been on good medication. It's good antihypertensive treatment. And that's actually the reason why they've made old bones. So I have a little bit of a disagreement with the with some of my aged care colleagues about that. But the message is, don't stop it. If it's working and it's not causing a problem, keep it going, because it's keeping the patient going.
Okay. If someone's 24-hour blood pressure monitoring has mild hypertension, but significant white coat hypertension, how do you think we should manage this?
So what you asked is
their 24-hour BP monitoring shows just mild hypertension, but obviously when they walk into us and we take their blood pressure, it's much more significantly elevated. How do we manage this? Like trying to take it on our readings, obviously it's not.
So this is a difficult area as well. What I tend to do is I work out, when I report ambulatory blood pressure monitoring, I look at the load of the blood pressure. And if the percentage of time that the readings are above 150 over 90 is more than 20%, then I treat it. If it's less than that, and you can see often on the ambulatory monitor that the highest readings are when the monitor was first put on, and then when the patient brought the monitor back the following day, and all the readings in the middle are all normal. So the white coat hypertension applied when they saw the technician who put the device on. That sort of patient will often have a blood pressure load of maybe 10% of all the readings, and I don't think they need to be treated. Or not with drugs, at least. Treated with lifestyle changes, yes, but not with drugs. The problem is that these patients who've got white coat hypertension most of them will later develop proper hypertension. So white coat hypertension is almost like a precursor to hypertension, which is more serious later in life. So you need to follow them up carefully, and particularly if they've got other cardiovascular risk factors, that you should have a lower threshold for treating them as they get older, and not just dismiss it as all white coat. What I tell the patients to do is, keep a close eye on their blood pressure at home, and have their own device, blood pressure monitoring machine at home, and keep a little diary and see how it's going. And often I would give them a very small dose of antihypertensive treatment to take at night. I always give it to them at night, because they're much less likely to get symptomatic dizziness if they take it at night. And the general thinking is that if you take your blood pressure pills at night, you've got that protection against that surge in blood pressure first thing in the morning when you wake up, when the risk of heart attack and stroke is at its highest. So you might just give them like candesartan 4 milligram, and then just monitor it, and then let them take some readings and see how you go. And in many cases, it will work out really well, and they will actually come back and say that their readings at home are perfect, and you don't have to worry about even measuring their blood pressure in the surgery when they come to see you, because it's often going to be falsely high.